My name's Dr. Ross Cutts and you're watching my surgical video of placing a Straumann 4.1mm diameter by 10mm length tissue level implant. This is a surgical site of a previously removed lower right 6 first molar that was taken out approximately 3 months before. We can see that we've got really nicely healed keratinized mucosa, and there's a slight loss of the buccal ridge. We start by making a papilla sparing vertical incision. This is the distal incision. And then we just go full thickness past the mucogingival junction. And then we repeat this with the mesial. And as I said, we are papilla sparing, so preserving the distal papilla. This helps to prevent recession. We then use a 12 blade to make a semilunar incision along the crest. This, we will see later, helps to shape the keratinized mucosa around the tissue level implant. And again, full thickness. We then use a little elevator to just raise the flap and the periosteum. In this case, this is a Buser elevator. We use the pointy end that just helps to raise nice and cleanly. Then we just elevate buccally and lingually to expose the alveolar ridge. If we need to, we can just extend those vertical relieving incisions, and then we're just placing the implant freehand. We've already CT scanned to assess the alveolar ridge, and here we're just making a little marker with a small round burr, and then we increase the diameter of that. This helps us to get drill accuracy, and then we work through our drilling protocol. We have a needle burr to start, and we go to full depth of 10mm, checking angulation all the time as per our CT scanning planning. Then we go up in the diameters of the drill, using an 800 RPM drilling speed. That's our direction indicator. Then once we're happy with the initial pilot hole, we got the drilling diameters. This is 2.8mm in diameter. And then we check with our direction indicator again to depth, angulation, ensuring that we can make a screw retain restoration. And then our final drilling diameter of 3.8. And we work slowly to full depth. And this is where we can see that post-extraction, the socket remodels, and we lose that tiny bit of buccal width. And that's our final direction indicator. And then we just tissue profile. And that's for the neck of the tissue level implant. That's at 350 RPM. You can see that we've got a nice healthy remaining dentition. Here we're going to use a simple maxresorb product from Botis and Straumann. We place our tissue level fixture initially by hand, and then using the torque wrench to enable it to go to full depth. We have a shorter implant driver replaced then with a longer implant driver to prevent impingement from the adjacent teeth, so that we can get the fixture to total depth. Checking that the index is aligned bucco-lingually. then we can see we've just got a slightly thin buccal profile. So we're going to just use our maxresorb to increase the thickness buccally to give us that 2 mm circumferential bone or bone-like material. This is the angulation of our freehand implant. You can see it's nicely placed for a screw retain restoration. I just mix up the maxresorb with a little bit of the SLA active solution. We're going to place a cover screw so that we can close the site, not completely. And then we just place this subperiostally, so the periosteum acts as a membrane in this case. We haven't got any exposed fixture threads, so I'm not necessarily worried about using the biomaterial to support the implant fixture. This is all about using the biomaterial to support the gingival keratinized mucosa, which we can see is starting to thicken. And we can see that our semilunar flap approximates around that tissue level nicely. And then we just use make a little nick in the mid-lingual flap just to allow the lingual tissues to curve around the tissue level fixture. And then some simple interrupted sutures just to help close the site. We don't want to advance the keratinized mucosa. We don't want to move the mucogingival junction, because then we'll lose volume of keratinized mucosa, which is incredibly important for our definitive screw retain restoration. So we can see that it's just nicely bulking buccally. So two simple interrupted sutures crestally, and then we're just going to help support the mesial and distal vertical relieving incisions with another pair of interrupted. And we can see that the site closes nicely. We know that with a tissue level fixture, it will be transmucosally healed anyway. And that's our simple tissue level surgical placement. All done, nice and neat.